Hello, and welcome to another episode, Infection Control Experts in Conversation, hosted by Innovos. The podcasts, with the help of national experts, aim to support IP&C teams in the real NHS world by offering advice and suggesting pragmatic solutions to drive down healthcare-associated infection. My name is Liz Waters, a recently retired consultant nurse with 22 years' experience in the IP&C world, although I am back in the thick of it again, supporting a health board in Wales. Our next podcast focuses on ventilation in NHS premises, a hot topic of conversation in the infection control world since the start of the pandemic. If you are lucky enough to work in a new hospital, I have no doubt there will be state-of-the-art ventilation systems. But what about our old estate, which has some ageing systems or none at all, relying on neutral ventilation? Today, Sarah Wheatley will be joining us and will be helping us to unpick this thorny issue. She will describe her journey with ventilation in a healthcare setting in Bristol, and I'm particularly keen to hear about the relationship she had with IP&C teams as a one-time operations manager. Hello, Sarah. It would be
Hi,
fabulous.
Liz.
Hiya. It would be fabulous to hear about your career so far.
Oh, hi, Liz. Thank you for inviting me. I'm Sarah Wheatley, and I'm the Head of Service for Infection Prevention Control and Tissue Viability at North Bristol NHS Trust. I've worked for MBT since 1989. I took a slight gap in my career and went to work for the walk-in centres and NHS Direct, but predominantly I've always worked for MBT. I've worked as a clinical site manager and an operational matron, and did that for many years. And in 3 years ago, actually, 2020, I decided to go and work for the digital team, and I only did that for about 6 weeks because the pandemic was in its full flood then, really, and we needed to have some leadership within the team because some leaders had recently left. So I joined IPC and obviously came from it from an operational background, and have been there since, and have studied a master's in infection control, and have just graduated from Florence Nightingale Foundation with a
Congratulations.
so
Yeah, highly prestigious. Yeah,
so I've been
congratulations.
really lucky. So yes, I've brought a different slant, if you like, to the work that we do. I think we've made some really good changes in terms of how we interact with the operations team. We talk to them on a daily basis. We have Wi-Fi phones now rather than bleeps. We are very focused on what does it look like for our patients on a daily basis, and we get very involved in the operational running of the trust with the IP&C needs that we need to add in. So we're always on the bed meeting. We're working to a 7-day-a-week service now, and we're very integral with the changes and the way that the patients flow around the hospital, really. And that's the major changes. I think traditionally IP&C and operational management have clashed, but we've broken the boundaries of that a little bit. My team go and work with ops come and work with us, and we definitely have a more collaborative working
Oh,
process now.
that's fabulous. So the level of risk assessment that must go on between operational teams and infection control teams must be phenomenal. Trying to balance the beds versus outbreak wards is very, very tricky indeed. And if you don't have that relationship with the ops managers, it can get toxic at times. So you're absolutely right that the relationship between operational and infection control teams is absolutely crucial. So it must give you a really rounded view, having worked on both sides of the equation as such.
Yeah, I think so. I think it doesn't come without its complications, as
Yeah,
you've just said.
absolutely.
And
Yeah,
even though I describe it in a very collaborative working way, there are still some difficult conversations to be had,
absolutely.
like there always will be. North Bristol Estate is a tale of two halves, if you like. We have a new build, a PFI build, plus we have what we call retained estate, which is the older buildings, like you've referred to in the introduction. So
Yeah.
it is difficult. We do have a lot of single rooms, but equally we do have areas where we have open areas, and that's particularly the area of which we needed to focus on when we looked at ventilation.
So I understand you were successful in putting forward a case for the installation of some aerial 1000 air purification systems. Can you describe that journey?
Yeah, absolutely. I think I was very lucky in many respects that I have a trust board that ask us to be curious. They ask us to look at new technology. And this was just as the pandemic was really at its height, where we were really looking at the nosocomial spread of patients within the elderly care environment and the fact that we had quite a number of outbreaks at that stage. So I really looked at the technology that was out there. I looked at a lot of portable air purification devices, and I also looked at what that would look like and how would that look in the wards that we had problems with. And that was initially where our journey with Innovos started. We looked at the portable devices and we put those in place in some bays in our elderly care area. Quickly, we realised that they look like quite large shredders, really, or bins, and
Yeah,
we were getting quite a lot of things being put in them by people, by patients, thinking it was a bin. And also, there was a slight conversation about whether or not these would be trip hazards. And we didn't actually get a problem with a trip, but there were a lot of conversations about the clutter in the bay and whether or not that would work. It just so happened that at that point, the air handling units were being looked at in the area that we were talking about.
uh,
And I had a moment where I was able to really look with Innovos at the aerial 1000s and look at whether or not that would be the right time to think about putting that in. And like I say, I've got a very a trust board that asked me to be curious and they asked me to look at different things, and I was very lucky that I had a finance director and a dipsy that was very welcoming to the fact that there was new technology out there and we should give it a go. So in many ways, everything aligned. And I'm not
yeah,
sure that, I think it was a moment in COVID where we were asked to look at what was out there from a technology point of view. And it wasn't that money was no object, but it was very much you were encouraged to look at things in a different way. And I think particularly since I've now studied and done F&F study, and they talk about elevator pitches and they talk about all of that, how do you get your trust board online? It was a very sweet moment that I could absolutely say, do you know what? I've noticed a difference with the portable units, but the portable units come with some issues, and the
yeah.
issues are upkeep and all of that. And actually, we've got a minute in time now where we've got an air handling unit change and we can get this done. So I think everything pointed in the right direction for me.
It just sounds fabulous that you have an executive team who are just so open to your suggestions, and they went with you. Have you got any hints or tips as to how you can bring executive teams on board? I'm just always mindful that as well as infection prevention and control, they've got a million and one things to juggle. So what did you do that made you sort of stand out as such?
I think it's a culmination of a few things. I think
Yeah,
it's describing the problem and also describing the research that you've done around how you're going to mitigate that and what does that look like. Also opening their eyes to what's out there, because technologies have changed, and you need to be able to be understanding of that and present them with an argument of this is what it looks like, there's some efficacy on this. Also, the other bit is patient stories. Patient stories are really a really strong way of saying, look, this is what this looks like at the minute. And I also fortunate at that time I was doing my dissertation on my master's on this very subject, so I was able to pull in a lot of research that had happened already, as well as my observations of what had happened on our units and around how that could be improved. So I think when you present that data, it's very powerful, along with patient stories. And also, you just need to talk to people about the technology that's out there. You need to, my facilities people on that ward know about that technology. Everybody that goes on to Elgard talks about it, from the clinical director, right through to porters and to domestics and everyone else. I think you've just got to get everybody involved. And I think that's probably the voices of those people, and understanding what that looks like is also a very helpful tool as well.
Yeah, it's like a collective voice, really. It isn't just you banging the drum here. You've brought everybody else on board, haven't you? And that collective voice then is strong in terms of changing executives' minds as such. I recall when I did business cases, it was for the the Innovos HPV machines, and they were very keen on, so what are the benefits, around this. And correct me if I'm wrong, Sarah, but from an Aerial 1000 perspective, I'm guessing that the benefits not only include preventing COVID outbreaks, but other respiratory diseases as well, so influenza, etc. And again, I'm guessing, because I've not looked at the evidence in detail on this, but not only are you preventing cross-infection between patients, but you're also protecting staff from picking up respiratory infections as well. Do you think this is an area of research that the IP&C will need to be pursuing? What's your thoughts on that?
Yeah, I think so. I think there's quite limited papers out there, really. I think there's been a lot more since COVID, naturally, but a lot of them focus on theatre settings and more your high consequence of disease areas, and I don't think there's so much on general wards, although there are, a number of papers now. I think the thing that you can do with the Innovos 1000 unit is you have it ticking over at a normal level. And now on that unit, if we have a pop up, we can increase the speed. So then you're promoting more airflow as well. So whilst you have it at a ground level. And then the other thing that people talk about is they say, these units, are they noisy? Do the patients complain about them? And I have to say, the ones in the ceiling are less noisy than the ones that are portable. So, and but then the only other complication is around making sure that you get your filters changed regularly and you have the upkeep as well, because that's really important with these things. All of these devices are only as good as how well you keep them up and you look after them. So I think there's a lot to be said for working. It's a constant learning situation for us, because we will still get pop-ups. I can't tell you that it doesn't eradicate it, because it doesn't, but it's how you then manage it and how you then increase your airspeed to accommodate for what you've got going on in that bay at that time.
Yeah, I mean, when we chatted before we had this podcast, you talked about the fact that when you have a pop-up case of COVID as such, that somebody literally needs to press the button to increase the speed, and it's human factors at the end of the day, isn't it? So someone may or may not, they forget to do it, and the consequences might not be good. I suppose it's about what processes you put in place to try and reduce that human error. Have you, because I know this has been a bit of an issue for you, so have you put any kind of processes in place to try and reduce that level of human error?
Yeah, again, it's lots of education with the ward. It's a lot of my team working with the clinical teams, telling them the picture that they see. Automatically, to be fair, a lot of the teams know now that they need to increase the airspeed, or, if someone's come across, or they think someone's a bit snivelly, they've got some symptoms that they don't know what that looks like, they'll automatically up the speed. So I think as we've moved through the months of having the devices, we've kind of learned what this looks like.
Yeah.
But again, you're right, human factors play a big part in this, because it's not always set at a certain level, and you wouldn't want it to be centrally set so it was at a high speed all the time.
Yeah, absolutely. And how easy is it to actually turn on that switch as such? It must be on the ward somewhere, is it? That
They're all on remote controls. So they're all up in the
right.
ceiling, and then you
Okay.
just have a remote control like your television that you
Yeah.
just point at it, and that changes your speeds. Really easy to operate. And also the screen on the actual device absolutely tells you what mode it's in, and they're really easy to interpret. You just do some quick how-to guides for wards,
Yeah.
and they understand what that looks like. And I know a lot of trusts have done SOPs and how-to guides for the portable units, so it's no different really.
Yeah. Okay. So it's just about embedding those processes, it really, isn't it? And it
Yeah.
sounds like you've been on a journey and you've got there. But thank goodness. Um, Sarah, what about outcomes then? You know, since you've had the Aerial 1000 in situ as such, what have been the benefits? What have been the outcomes? It'd be really interesting to hear that.
So I think when we first had them put in, we were still in COVID was still very predominant. We were all still in masks. You know, it was still not at the peak, but we still had many cases. So I think right at the beginning, we noticed quite a significant drop. But at that point, we were still testing a lot of people. And obviously now we don't test as many people because we
Yeah.
wait for symptoms. So I think it's kind of difficult to say categorically in many ways, because obviously the prevalence of infection has dropped, or
Yes.
we've just started to see a little increase now because of winter. But there was definitely a palpable change when we put the mobile units in, and then again we noticed a massive decrease when we put the aerials in. So but again, we are probably a lot lower than some other areas where I know they have ward areas that are open, more open, like the ones that we have in our elderly care unit. So
Yeah.
I think there is a drop. What that percentage looks like is difficult to tell, because you need to marry it up against the percentage in the community really. So it's hard to say, but there's definitely been a change, and definitely the ward sisters in the two areas that we've put them in comment on that on a regular basis.
Yeah, I mean, it's difficult to look at community transmission now because people are not testing anymore, are they?
Mm.
I was out last night with some friends, and some of them had been to a wedding last weekend, and they've got a whole house full of COVID. They weren't symptomatic, thank goodness. I wasn't enthralled about being in their presence, I have to say, having heard that. So I think it does sound as though there's a lot going on the community at the moment, but as I say, it's difficult to establish that when there's so little testing going on. But I think the whole outcome data is fascinating, and as you are someone who is at the forefront of putting this technology in, I think people will be looking to you and others who have been successful in getting the technology in to watch closely about around outcomes really, and not just from a COVID perspective, but flu and other respiratory viruses as well. So you're in the forefront there, Sarah.
Yeah, we've been lucky actually. We've had quite a lot of people come to us and ask us about the technology,
Yeah,
and a number of trusts have reached out to us, and we've spoken to them. I think it's more challenging now from a procurement and business case situation to get these things through. And like I said earlier, I think I had that moment of opportunity, and it is a little bit more challenging to my colleagues that I speak to, where they've asked to look at the devices now, because obviously the financial envelope is a little bit more of an issue to tap into.
yeah, yeah. But as we all know, we got to weigh it up against the cost to the patient and the cost to the organisation in terms of bed losses, and trying to put that into a business case is particularly tricky. I have to say. What kind of hints or tips could you give to an IP&C team who are trying to put a business case together? Is any advice you could give them at all, Sarah?
So I think bed loss days, like you've touched upon, is really important. We do a sit rep every evening when we have outbreaks, or well, we don't have outbreaks so much anymore, but when we have incidences of increased infection, where we're advising everyone on the beds that we've needed to monitor, particularly if we've got patients that are contacts. So, and usually, there's a lot of conversation around if those numbers go above, 5 or 6, particularly if you've got operational pressures. So I think lost bed days is quite a palpable
Key.
kind of key matrix, if you like, as well as those bits like patient stories. How does it help staff? You can get Oki Health involved. There's other kinds of strands to this that you can pull in, because it tells a wider story. So I think I basically think nothing's off limits really with describing the problem, and I think that's the issue. I think you've not got to have your blinkers on. You've got to describe the whole problem rather than just what you see in front of you. And I think that probably helps people really understand the problem that you've got in front of you.
Yeah. As I said in my introduction, that I'm working for another health board at the moment, and I was looking at a business case that I had pulled together about 3 or 4 years ago, and I was looking at it and thinking the complexity of it all, the template that I was given, it was seriously complex. So my question to you really is, if you've got a business case there, would you be willing to share it with other IP&C teams who may be struggling with that aspect? I mean, let's face it, infection control nurses came into nursing because they wanted to be a nurse. They don't have the experience in writing business cases. So I just feel that there is a need to help them. So would you be happy to do that, Sarah?
Absolutely. Yeah. My business case was co-written with my facilities team. And I think that's the other important thing to stress,
Yeah.
so because my facilities team keep the upkeep going, they have a contract with Innovos to maintain the units. Like we said earlier, it's not just about putting the units in, it's about how you look after them. So yes, that's the reason why it's a co-written business case, but very happy to share.
Brilliant. That makes absolute sense. I mean, I recall the HPV business case, and absolutely facilities were key in all of this. Because certainly from an HPV perspective, they were the ones that were operating this machinery, and they really need machinery that is user friendly, simple to use, and absolutely you need that service contract, because the support that Innovos gives in these service contracts is just so valuable as well. When you were deciding, when you decided to go for the Aerial 1000, what sort of benefits did you think it had over other competitors, Sarah?
So we hadn't come across any other provider that had anything in the ceiling, and particularly when you
Okay.
look at the portable units and I was talking about earlier about potential trips and hazards of that. Um, I think we were getting to a point where we were thinking we hadn't actually purchased the portables, we had them on hire, and we were kind of playing around with different brands of them to work out what would work. And I think it was then I went back to Innovos and said, look, I'm a little bit worried about what's going into these machines. We'd had a couple that we needed to have sent back because we had, you know, cups of tea put in them. I think one of them, and I think we had rubbish put in another one. Think people thinking it was a bin.
Yeah.
So that's when they came to me and showed me about the Aerial 1000s, and then I did a little bit of a search around to see what else was around, and there wasn't at that point. So that's how it all happened, really.
And the support that Innovos gave you as well. I can't talk highly enough of them over the years that I've worked with them. So I'm guessing that played a part in decision making as well.
Absolutely. I think they were just really they listened, they understood the problem, and they obviously were there to offer a solution. In fact, with the aerials, and that was the main thing. Although obviously we did our own independent research, they provide us with a lot of information around what that looked like and the upkeep and what that would look like going forward, and that was just very helpful in making that decision.
But it sounds like a fascinating journey you've been on, Sarah. Is there anything we've missed here that you wanted to get over at all?
No, I think that's it. It's been really lovely to chat to you.
Yeah, it has been great. I just feel that we are in a different world from where we were pre-COVID. Nobody gave ventilation that much thought, to be quite honest. And bearing in mind that we're going to be dealing with old NHS estate for some period of time, I think we do need to look at how we can mitigate respiratory infections now. I know the debate about whether COVID is airborne or droplet is still surprisingly on the go. But I think putting in technology such as the Aerial 1000 is going to absolutely mitigate risks in terms of any respiratory infection. So, Sarah, thank you so much. It's been great talking to you. Since I've retired, I've missed those conversations with IP&C teams, which is why I've still got a foot in that camp. And I'll be at conference. I don't think you're going to be there, unfortunately, but your team are. Is that correct? Yeah.
They are. Yes, I've been looking at kind of sustainability. So I went to the IPC Sustainability Conference and did quite a lot of work with them. So one of my team are going to go to the national conference, because I'm going to be focusing my attention on IPC week and getting out with clinical teams.
Oh, fabulous. And anyone listening who is going to be at conference, of course, Innovos will have a stand there. I'll be there at the lunchtime slot. So come along and talk to Innovos about your technology needs, be it HPV, UV, or Aerial 1000. Sarah, thank you so much. Great talking to you. And please keep us updated with the outcome data of this fantastic initiative. Thank you very much indeed.
Thank you. Lovely to talk to you.
You too.